All right. Okay, this month's Con Ed is special needs. It was done by, obviously, as you can see by the picture, the lead ambulance medics put this one together. So there's a lot of things that we're going to be going over today. A lot of it's the special needs and dealing with patients that have special equipment requirements that you guys may come in contact with out in the field. What you need to know about them. Again, like I said, there's some slides I'll probably skip over because I'll be talking and I'll just forget to change the slide. Others, we'll see it later on, or I've already covered it. So the devices that we're going to go over as far as cardiac are going to be pacemakers, AICDs, talk a little bit about the defibrillators, LVADs, and central lines. Now, we've covered central lines every single month this one, so I'm going to say as little as possible because we've already covered it, just as a refresher. Talk a little bit about the equipment, how you handle it, different signs and symptoms of treatment to deal with some of these patients. So I'll start off with pacemakers and defibrillators. So the defibrillators that you might see having implanted in somebody is because of the fact that they have irregular rhythms like SVT, VTAC, VFib, they go into it for unknown reasons. And the implanted defibrillators then will recognize this and they will go ahead and shock the patient back into hopefully a regular rhythm. Interesting enough, and I really wish there was some documentation on this or some evidence, but I can tell you that I've seen it where people's defibrillators are going off and they call you because their defibrillators are going off and they don't understand. You put them on the monitor and they may be in a regular rhythm, but it's a malfunction for whatever reason. It's painful to these people. What do? We don't actually have a set protocol for these patients. What we can do is, because they're in pain, we can go ahead and administer fentanyl for the pain, or even, for that matter, we can give them a little bit of Versed, like 2 milligrams every 2 minutes to a max of 10. Interesting enough, and I don't really know if this has anything to do with it, I don't have any scientific evidence behind it, but the last couple times I've used Versed on patients who have been, their defibrillators have been going off, it's actually resolved the problem for whatever reason. So I'm not exactly sure if that has anything to do with it. So pacemakers are implanted in for generally those patients that are normally in heart blocks or bradycardic type rhythms. It's to keep the heart set at a specific rate. A lot of the patients that have pacemakers in place will know what their rate actually is. So you can ask them, what is your rate? Or if you feel the pulse, you'll know exactly approximately what their rate is. We know that if a heart rate's too slow, we have a decrease in the cardiac output. So we're trying to go ahead and keep the rate up there a little bit so that the end tissues are perfusing and the increase in the cardiac output for the heart. So how does it work? Well, it sends impulses through the heart to keep it going at a regular rhythm. It is, there's various electrodes that are implanted in the heart. Some are in the atria, some are in the sinus node, coronary sinus node, and some are right down in the ventricles. It depends on what kind of pacemaker it actually is. And it's designed to go ahead and detect the heart if it goes into a rhythm that's too slow, or even if it goes into a rhythm that's too fast. But it's mainly there to adjust the heart rate based on the patient's need. Some of them are demand pacemakers, some are continuous pacemakers. So we take a look here. The pacemaker, usually they're in the upper left chest. It doesn't mean that they're always going to be there. There could be an abundance of scar tissue on that left side that they may actually have to put them on the right side. Goes up through the subclavian vein, down the vena cava, and you can see how it sits right in the atria. There's the ventricle, and there's in the coronary sinus. So it's all meant to go ahead and deliver some type of impulse based on whatever condition the patient actually needs. There's dual chambers, they last about 6 to 10 years, and then the single chambers can last 7 to 12 years. So when we look at them, why do people, it's bradycardia. You guys might have a patient who's got a heart rate in the 30s, and they're symptomatic. So you put them on the pacer, you start them, you've tried atropine isn't working, so you go ahead and you pace them. In the hospital, they'll put a transvenous pacemaker in, and then to the point where they can get them having a permanent pacemaker put in. We see a lot of times with blocks, but we're talking about the higher blocks, the second degree type 2s and the third degree. We see a lot of people with third degree or first degree blocks that it's really irrelevant. They don't have to worry about having any pacemaker put in. We see them quite frequently. Second degree type 1, we're getting to that point that obviously can go ahead and progress into a higher heart block. Ones that have fast, irregular heart rates that maybe you need something to slow them down. There's also, with the defibrillators, that can go ahead and slow them down. You could have two where the ventricles, remember when the ventricles contract, they go from the left to the right as far as their contraction. And if there's any strong delay between the right and the left, depolarizing, this will actually help fix that problem. So if you're looking on your EKG monitor, some of the things we're looking for is that pacer spike. And we want the pacer spike to be right before whichever area it's looking to go ahead and capture. So if it's a ventricular pacemaker, we want it right before the QRS complex. Remember, the QRS complex will be a little bit wider. If it's an atrial, it could be right before the P wave. Sometimes you'll see a dual, atrial and ventricular pacemaker. We're looking to see that the pacer spike does occur right before. If it doesn't, it may mean that it's not capturing. If we see it capturing, we want to check the heart rate to make sure that the rate matches with what it's set at, to make sure it's set at the right rate for it. Here's an atrial pacemaker. You can see that our pacer spikes are coming right before that P wave. And then the ventricular, you could have a bradycardic rhythm and then all of a sudden it kicks in on the ventricular pace rhythm, and you want that pacer spike right before that. That's what you're looking for. So we know that some of the newer models of pacemaker have dual capabilities. They can also operate as a defibrillator. Some of them, it's easy. They can go ahead and put their cell phones up to them to go ahead and transmit any data to the doctor's office that they might need to go ahead and, if they've had an episode, let their physicians know. It's easy to do. Some of them too might have some of you guys might remember seeing the larger magnets, which we could actually stop the pacemakers from working. We don't do that anymore. Especially if there's runaway pacemakers, we let the hospitals go ahead and handle that. If they have a defibrillator, it will go ahead and shock any life-threatening arrhythmia, whether it recognizes VTAC or it recognizes VFib. It will go ahead. Now, some of these shocks, again, are going to go ahead and they're going to be painful for the patients. So giving them some fentanyl, giving them some Versed before, when we know this is happening, could be beneficial to them. We might anticipate some problems, one, if the battery is starting to wear out. However, when they go in and they have their doctor's office check it, they can see approximately the battery life. Sometimes you'll have broken leads or electrodes that will get pulled out of position that can cause issues for them. Electrolytes imbalances will be an issue. And then you've got your electromagnetic interference, arc welders, powerful magnets, stereo speakers, and even metal detectors can sometimes cause an issue with pacemakers and defibrillators. So how are we going to know if someone's pacemaker is malfunctioning? Well, if it's shocking them, they're going to obviously tell us if they're able to. But we're taking a look at what their mental status is. Is it altered? Are they hypoxic? Remember, one of the very first reasons a person, when they become hypoxic, they have altered mental status. Someone might complain of being lightheaded and dizzy. They might complain of chest pain. And the big one is the hiccups that won't stop. Could be a problem for them. So if they have any of those that, with their pacemaker, you might understand that it might be malfunctioning. We want to make sure that if they have a pacemaker or defibrillator that is malfunctioning, that they are transported, put a cardiac monitor on them. Might want to even put your own pads in place to go ahead and see if you can't override the pacemaker that's already there, to make sure that their heart rate does increase so that you can start increasing that cardiac output. Okay. We'll treat any cardiac arrhythmias with whatever appropriate interventions that we see. If they're in VTAC with a pulse and they're stable, we'll do the amiodarone. Well, adenosine first and then amiodarone. If it's something that makes them unstable, then we may need to shock the patient. So, If you have to go ahead and put the pads on a patient who does have a defibrillator or pacemaker in place, we don't want to put them directly over the device, we want to put it above. So if the device is in the upper right chest, we'll put it up a little bit higher. But remember, American Heart does say that, yes, we can put the pads in the standard positions, we can put them the opposite, we can put them front and back, we can put them on the sides. So there's 4 different acceptable locations to put defibrillator pads on a patient if we're experiencing an area where you can't normally put them on. Left ventricular assist devices. Left ventricular assist devices are devices that are put into someone if they're planning on having a heart transplant and they've got to be on that waiting list for an extended period of time. There's also if a patient is just trying to live out their last few days. Maybe they're not eligible for that heart transplant. They don't expect to live for very much longer, but they'll go ahead and put this in place. And it's as a way to go ahead and circulate blood throughout the body. We usually see the ejection fraction on these patients be less than 30. So that, what does that mean? You're still going to see the electrical activity in the heart when you put them on the monitor. Normal P-wave, QRS complex maybe look a little bit different than the normal, but you'll still see it. You'll still see people go into V-fib, V-tach, bradycardic, tachycardia, you know, whatever the arrhythmia is. And we're going to treat them as we see them. The only thing is that with the heart having, it being as weak as it is, the pump is there to circulate blood throughout the whole entire body. Now the common one that you guys are going to normally see is going to be the HeartMate 2. That's the one that they're currently using the most of. HeartWare is still out there. It's the second one. I don't know of anybody in the area that is actually using the HeartWare. The DuraHeart is another one that's out. I think they're still seeking FDA approval, if I remember correctly, for the DuraHeart. But look at how they used to start. This is the original HeartMate compared to the HeartMate 2 right now, the size difference between the two. And that was actually implanted inside the chest. So if you take a look here, let's see, a better picture on this side, yeah. So you have some corrugated tubing that goes right to the left ventricle here. And instead of going up and through the aorta, it's being circulated with this power, this continuous pump, if you will. And it'll force the blood up to the aorta and out to the rest of the body. How do you know if the pump is still working? Well, it's very simple. You take and you put your stethoscope just underneath the rib cage on the left side. Listen for a whirling sound. If you hear a whirling sound, then the pump is still functioning and pushing blood throughout the body. With these also, you know, in the past we've told you guys before, don't do CPR on these people because this corrugated tubing that goes to the aorta, if you look where your hand placement would be, it would be likely that you would kind of tear that out of the aorta, patient would exsanguinate and die. But now they've actually come to the realization that, you know, either way the patient's going to end up dying, so we'll give them a chance with doing CPR. You will also, on the right side, in the upper quadrant, you'll see where the drivetrain will come out. It'll be a cord that'll actually exit the abdominal cavity. Kind of look at that area to see if there's any infection. Is it red? Is it warm to the touch? Does it have infection around it? You know, anything that's green or yellow. And then it goes to a control module. Each person will actually have 2 control modules available to go ahead and change out if necessary. And then on the side of them, they're going to have a battery pack, which is one on each side that they kind of wear as a harness to keep that control module going. So with these patients here, blood is going to come in, goes back in through the, you know, out through to the lungs, comes back in through the left atria down to the ventricle, and it's going to be sent out this way and come up into the aorta to the rest of the body. That's how it's actually going to go ahead and work. Some of the things to realize that with these patients, you're probably not going to be able to feel a pulse. It's a continuous flow of blood. Now yes, the heart does still have some electrical activity and it is doing its own pumping motion, but a lot of times it's going to not be enough to actually go ahead and feel a pulse. If you have a Doppler, yeah, you might be able to go ahead and be able to pick up on that pulse. Same with the blood pressure. Blood pressures may not be readable. Pulse oximetry may be wrong. So you want to make sure that you're using your BLS skills to really go ahead and assess these patients. Check the skin parameters. Check to see, what's their mentation. That's what you're really looking for. Yeah, waveform could be flat on your pulse oximetry or pleth, so you know it's not adequately working. Take a look, put your 12 lead on them, start an IV. One of the more common problems that we see with these is that these patients are dehydrated, and so it could be just as simple as giving them some fluids. Make sure all the wires and connection are there. Now, I know a lot of you are like, hey, I know nothing about this. I'm not touching it. If you have a family member there, these family members are really put through the ringer as far as teaching them how to monitor them, use them, and make sure they can troubleshoot these devices. They don't like to go ahead and discharge these patients home unless there's someone there that they know can troubleshoot them. That doesn't mean that the family member is not going to freak out though when they need you, and that's the reason they call. If that's the case with these family members, big thing, make sure the connections are tight. You can always go ahead and call the LVAD coordinator. So they're going to have a black bag, small, kind of about the size of a small shoebox bag. In the front pocket, they're told to keep their medication list and the name of their LVAD coordinator in there. You can contact the LVAD coordinator. Now, I will tell you, we do not want you transporting to those hospitals, because that's what they're going to want. They're going to tell you, bring them down to Christ. You're not going there. Bring them to one of the closest hospitals. We will go ahead and stabilize them, and then we will transport them to one of those facilities. However, the hospitals here, we don't have the capability of keeping a bad patient because we don't have a lot of the equipment. We don't have the battery packs for them or the battery charges. There's also a power-based unit, which is about the size, if you guys, your boots that you guys wear, it's about that size of a shoebox. Take that with you. And I only say this from experience because Winthrop Harbor actually had a patient who was on an LVAD. And they didn't check the batteries 100%. They thought the batteries were good. They sent the patient to the hospital, and they sent the power-based unit with the wipe. Well, she drove all the way out to Mundelein to pick up her sister, and then they went down south to do something else before they actually came to the hospital. And it was literally almost 4 hours later that they got to the hospital, and the batteries were coming very close to being dead. So we want to make sure that the hospitals can charge those batteries if necessary. It doesn't take that much room. It's, like I said, a small little box. You guys can take that right away with you in the ambulance so that if for some reason that those batteries need to be charged, it's right there. With these, if you have a patient who is unresponsive, not breathing, those are the patients that we're going to do CPR on. Okay? If they're not breathing, they're only circulating per their pump deoxygenated blood. So we want to make sure that we're giving them CPR at that point in time. Patients can be defibrillated just like you would any other patient. So we're going to treat the arrhythmias that we would see just like you would treat any arrhythmia with any other patient. If you look at the equipment and you see the batteries need to be changed, for the obvious statement, only change one at a time. Don't disconnect both of them because obviously they'll stop the whole thing from working, and we don't want that to happen. They usually will also, in their LVAD bag, they will have all the directions of any alarms so you can see what the alarms are, so when you call the VAD coordinator, she can kind of coach you through what you need to do. But the big thing to remember is it's going to be getting these patients to the hospital. Now, what if you're doing CPR on a patient with an LVAD? I spoke with Dr. Yee about this, and Dr. Yee's response is they don't need to load and go with these patients. They can still work them for 20 minutes, just like where you find them, and then make your transport decision after 20 minutes, okay? And call medical control if you feel the need to go ahead and withdraw resuscitative efforts on them. Yeah, just some facts. Don't remove all power sources at the same time for obvious reasons. You may not have a peripheral pulse or BP. SpO2 may register if perfusion is present but may be unreliable. If you defibrillate, don't do it directly over the pump. Also remember, a lot of these LVAD patients will be on heparin or some other anticoagulant, so. We do have a generalized protocol, and I don't want to say it's really a protocol. It's more of an information section. It's care of patients with LVADs, and it talks about exactly what we just said. Contacting the VAD coordinator. Make sure you transport the extra battery packs, chargers, cables with the patient. It says avoid water submersion, not that you're going to dump your patients in the water, but they can go ahead and take showers now with these without having to worry about them. Yeah, so it's just really some information that we just went over. Chest compressions are allowed for some of them, so. I don't know if you guys have any, but do you know if you have anybody with an LVAD in your district right now at all?
Yeah.
You do? Do you know where they're going to have theirs done?
Gary's house?
Gary's house?
Gary loves you about
Do you know if they go to Christ or are they going to Condell or North Shore? Not sure? Okay.
The pastor that you have problems with?
Turbocharged man.
Yeah.
The roads.
All right, we'll talk a little bit about central catheters, central IVs. We've been talking about these for the last couple months. I'm just going to kind of do a little bit of refresher. As a reminder, these patients will be patients that are receiving chemo, sometimes dialysis, sometimes medications on a regular basis, and that's why they have the central lines in place. We use them to give blood transfusion, medications, and IV fluids. We can do central venous pressure monitoring, well, not us, but the hospital certainly can. And it's mainly so that they don't have to keep poking the patient over and over, that their veins are pretty much shot. Depending on what kind of device they have, depends on how long that the device can stay in place. So if you take a look here, it goes through the subclavian vein, and the tip of it sits right at the top of the right atria. Can we access this pre-hospital? Well, they do say that you can access it pre-hospital if you call medical control in the event of a cardiac arrest. Some of the things to remember though, if you're accessing this, that when you go ahead and open up the clamp or take off the cap, you want to make sure that you obviously clamp it off first. Take your 10 cc syringe, put it on the end, draw 10 cc's of blood, and then hook up your flush, unclamp it, and then you can flush it with some saline to go ahead. And then you can access it, you can hook up your normal saline right away to it. Main thing we're looking at if we have someone with this in place is we're looking to see, is there any infection? Is there redness, red streaks coming from it? Does it look like it's got pus around there, green or yellow colors? The other thing we want to make sure that there is no breaks or anything in any of the tubing. If it is, you're going to use an occlusive dressing over the top of it. Big thing to consider is you don't want to cause any air emboli or any other emboli for these patients. Things that you're going to look for is that maybe the catheter has actually shifted a little bit and the position's gone wrong. You might see some type of arrhythmias if it's sitting in the top or touching the sides of the atria itself. Other things, you might see phlebitis at the insertion site, which is some type of infection. That's going to be the big thing to look for. So the pneumonic you can use obviously is DOPE. We use DOPE for a lot of them. Displaced, obstructed, is there a tamponade, pulmonary problems, or is it equipment failure? And you can go ahead and kind of work through each one of those to determine what might be the issue. So when we talk about obstruction, is there maybe a clot or a thrombus at the end of it that's causing an issue? So if there's any bleeding, direct pressure is going to be our first bit. I don't know how many of you guys actually carry hemostats with you for clamps. You can clamp it off. If you go ahead.
Gary has some in his pocket.
You know what? I think that's probably like one of the easiest and best tools out there. You can use it for so many things. Keeping blankets over the top of them to clamping off a central line. So,
Cereal in the morning.
yeah, eat your cereal, that'll work. So yeah, if you notice, always go ahead and clamp proximal to the end of the tube, okay? If you're ALS, you can go ahead and pull off that 10 cc's of blood, make sure you flush it, and then you can hook up your IV fluids if you have a patient with signs of shock. So, pretty standard, like I said, we've been pretty much going through that the last couple of months anyway. All right, some of the other things that we're going to look at is patients with ventilators. Now, the ventilators that they have at home are a lot different than the ventilators that they're going to have in the actual houses. Ventilators are usually hooked up to some type of trach to go ahead and provide continuous breathing because the patient cannot breathe on their own, whether it's some type of spinal cord injury or spinal cord damage. You know, for whatever reason, it's breathing. I'm not going to go into a whole lot, but the thing with the ventilators is going to be, if you don't know anything about it, don't touch it. Don't adjust settings on it or anything. I mean, don't adjust the PEEP, the FiO2s, the tidal volume, anything unless you actually know what you're doing at that point. Okay. Ventilators use positive pressure to give a mixture of gases into the lungs. Most of our ambulances don't have the mixtures unless they're a critical care unit. Sometimes the patients can go ahead and it's a ventilator that is a demand or kind of a demand that the patient goes ahead and starts, it'll go ahead and kick in. Others, it'll be consistent. It can be set to breathe at a certain rate, and it'll only go ahead and ventilate if the patient fails to trigger it. Kind of set amount of time. I'm not really going to show you this because this is more on the lines of what you're going to see at the hospitals. But like it says here, don't touch if you don't have training or knowledge. Most of the high-tech kids that we see that are on ventilators, or I think there's a nursing home that's a vent hospital. Is that in your area or is that in Skokie's? Skokie's area? I wasn't sure where it was at. But with these patients, if they're family members and they know how to use them, you definitely can go ahead and bring that vent along with you. As long as you have a family member that can run it. That's going to be the big thing. Otherwise, you can always call in, you know, critical care to transport that vent patient with you. Bottom line, if you can't find anything like that, disconnect them from the vent and bag them. That's the easiest way to kind of deal with it. Some of the things that you have to be concerned about if there's power outages, however, most of these patients that are on ventilators will have contacted the local energy companies and let them know that they're on. They'll have generators at home so that, oops, sorry. So that if there's electrical outage, their generators can go ahead and kick in for them. Some of the other complications might be pneumonia from being on the ventilators for long periods of time, skin infections and breakdown in the skin from the cuff of the trach. You can end up with barotrauma, pneumothoraxes, lung damage, and a lot of that is because settings are not done correctly. Oxygen toxicity, because of the FiO2 is not set right. Those are going to be some of the other things. So if you have a patient who's on a ventilator, check all the circuits. Have family members kind of go ahead and look over it. If it comes down to it, you can disconnect it and you can start ventilating the patients. And you can see here too, some of the little kids, they go ahead and have it right in the neck and where they'll have a permanent stoma put into place.
Service detail engine 22-249 Custer, Toyota natural gas outside in front. Service detail engine 22-249 Custer, 249 Custer. Citizens standing by, but there's an odor of natural gas outside in front. Repeat 88-13-15.
Standing by.
Oh, let's see here. All right, so tracheostomies can can be used for many different things. Some people that are on trachs will be hooked up to ventilators, others will not. It really depends on the patient himself and why they actually are needing the trach. But most of them is they have the inability to breathe on their own. Others will that they have damage to their airway, and for some reason they can't go ahead and inhale oxygen like you and I do. They might have paralysis of the muscles, which actually are going to affect any type of swallowing, or they might have some facial type injuries in which the tracheostomy is needed. So there's a couple different types. You have your uncuffed, your cuffed, and your fenestrated. Here's a picture of an uncuffed trach. This is pretty common for children. Children usually have uncuffed trachs. The cuffed trach, you can see, has the balloon blown up, just like I brought some in. And then the fenestrated ones, they'll have an inner cannula that you can actually go ahead and pull out and clean if there's any type of obstruction to it or mucus that may be attached to it. So when we look at some of these trachs, what do you need to check out? You might get there for someone who's having difficulty breathing. You can go ahead and try and ventilate with a bag valve mask through the trach, and if there's some type of an obstruction like a mucus plug, you can maybe push it down into the lungs. That works. Otherwise, you can go ahead and suction, and a lot of them will have suction or kits right there that has sterile water. You can put some sterile water down there to loosen up secretions, and you'll have the suction catheters that you can go ahead and suction them. Always make sure you're wearing some type of face shield, goggles if you're going to do that, because you're going to stimulate the patient to go ahead and cough and stuff will come out of there. That's probably not a good idea to get into your face. Otherwise, if you kind of go back to this one here, if you're still having problems, you can go ahead and turn this cuff. It just turns a little bit counterclockwise and pull out that inner cannula. You might have mucus attached to it, some hardened mucus. You can take and clean it. Right there is a trach cleaning kit. Otherwise, you could actually remove this all together and you can put a new trach in place. You guys, if they do have extra trach kits there, you guys are allowed to go ahead and put the new trachs in for these patients. If you're uncomfortable with that, there's two different things that you can do. One, you can take a 6.5 EP tube and cut it about an inch above the pilot balloon, pull the top connector off, and then put it right where you cut, and then insert it that way, just past the pilot balloon, blow it up. Or you can go ahead and take your quick trach, take the needle out, and you can just put the cuff or the cannula of the quick trach right in their stoma there also, to go ahead and be able to ventilate the patient if you need to. Some of the things that you're going to see, there could be damage to the trachea. Kind of look for any subcutaneous emphysema. If it's a fairly new trach, if they've done any damage, that means the trach has been damaged. They're getting air into that tissue around the neck, which can actually cause breathing problems. They might have a pneumothorax if any damage has been done to the lungs. Hematoma that can form in the neck and actually compress the trachea. Or you could actually have a misplaced or displacement of the trach tube. Sometimes people don't always like to wear the band that goes around the neck to kind of hold it in place. And sometimes you'll see that trach kind of come out. Just kind of tilt the head back and you can kind of slowly push it right back in and then secure it in place. And it doesn't usually cause too much of a problem. Some of the other problems that you'll see with it, bleeding, infection, tracheal stenosis, or narrowing of that trachea due to scarring. But the most common thing you're going to see is usually the mucus plug with them. What are you going to see if you have an obstruction? Well, stridor, high-pitched sounds are very common. They're going to be hypoxic, so they'll have altered mental status. They could be cyanotic, and ultimately decreasing oxygen saturations. So if you're going to suction a trach, make sure you're wearing proper PSI. Like I said, something covering your face is a good thing. Make sure you have suction all set up. Select the correct size suction catheter. Make sure that depending if you have like a The catheter should be half the size of the cannula for it. Insert the suction catheter and the closest hole on the tubing to start suctioning. And remember, always never suction for longer than 10 seconds at a time. Keep repeating until you can go ahead and have a clear tube. So, different groups. If you have a 12 or an adult, they might have an 8 to 9 size. So you're looking at probably a 16 soft suction or 16 French soft suction. Little kids, you're probably looking at about an 8 French for the soft suction catheters. We follow the same DOAC mnemonic for these patients: displaced, obstructed pulmonary problems, and equipment. Same thing with the ventilators. Did that tube become displaced? Is it obstructed with a mucus plug of some type or other foreign body material? Do we have a pulmonary problem, like a pneumothorax or pneumonia? And then, did we have an equipment problem of some type? Is there a malfunction with that ventilator? Maybe the oxygen tubing has been kinked, or your oxygen has run out. If you're a BLS provider, you can go ahead and disconnect and then call ALS if patient's on a ventilator. Suction, if necessary. If you're unable to ventilate, cover opening with gauze and ventilate with mask and bag over the mouth and nose. ALS, try ventilating again. You can attempt to remove it and then replace it if you need to. If you're unable to find the opening, try to thread suction catheter tubing through the new trach tube or ET tube and use the catheter tip to probe an opening and slide the tube over it. Some of the other things, if it's still obstructed, change it or use the appropriate ET tube into the stoma. Make sure you're reassessing the airway each time. Make sure you got good chest rise and fall and adequately ventilate the patient. If you need help, you can contact medical control. Okay? So, other patients, talking about GI tubes. Gastric tube, gastrointestinal tubes are inserted through the nose, the mouth, or the abdominal wall. They can be long-term, short-term, but they're mainly meant to go ahead and provide fluids, nutritional, decompress the stomach depending on what it's used for. You know, it really just depends. So J tubes, I can never say this, gyrostomy tubes, there we go, we'll try that, that'll be about as close as I'm going to get. Jejunium tubes can be used to vent the stomach of air and any other drainage. Can also be used to deliver any nutrition, medications that might be. G tubes are gastric tubes that are inserted to the stomach. Again, medications, nutrition can be put into there. Used for adults and children who require feeding tubes for more than 3 months. You can also go ahead and use them to pump the stomach. So if you take a look here, you've got the J tube that's actually put in at the jejunum as a way of nutrition, and then you've got your G tubes that are put right inside the stomach. One thing I want to say about these, and I'm going to skip over a lot with the pediatrics, but little kids that have problems with swallowing or aspirations, you know, a lot of times parents are going to lay that kid flat on the floor, and then they hook up the feeding tube to the G tube and their syringe, and they pour their nutrition down it, and they let it drain into the stomach. You want to always make sure if you're using these that the patient's head is elevated to risk aspiration for that patient. So, other problems that you sometimes have is they can be pulled out. If they get pulled out, just cover it with an occlusive dressing, transport the child or the adult. If it's clogged, we're not going to try and unclog it. You know, I mean, sometimes they can go ahead and try and flush it, but sometimes that nutrition gets pretty caked in there and it gets a little bit difficult to do so. Easiest to just let the hospital. Ostomy bags, depending on where the patient and what the patient means, I just tell people, leave them alone. I mean, as far as we're concerned, I'm not going to deal anything with them. I'm not emptying them. A lot of them will have, over the hole, the ostomy hole, there will be a wax-type disc that you'll go ahead and put, there will be a hole right over there, wax-type disc, that will actually, the bag clamps right on there, and clips right on there. That's to prevent any smell or anything from leaking. Again, if it's not broke, don't fix it. You might want to at least just check the site to make sure that it's not infected by any way. NG tubes, I'm really hoping that we can go ahead and put NG tubes in our patients if we're going ahead and intubating them to help decompress the stomach if necessary. But we know that NG tubes can be used for feeding, giving medications, or even pumping the stomach, doing gastric lavage to remove any type of toxins that the patient may have actually inhaled. PEG tubes, percutaneous endoscopic gastrostomy tube. Again, they can use for doing oral intake in the case of someone not being able to swallow or the fact that they're so sedated that they're not able to go ahead and swallow on their own. 13 to 40% of all patients with PEG experience minor complications. Mainly, we're talking about breakdown of the skin. Some of the gastric juices and contents might leak out onto the skin area, which can go ahead and cause damage to that skin. What are we going to do for these patients? Well, not a whole lot. Cover it up and go ahead and transport. That's probably going to be the best thing for them. We're not going to do anything as far as giving medications. We're not going to go ahead and try and fix them anyway. It's just easier to take them in and let someone that does know how to deal with them. Children, again, he put these in here with the children. I'm not going to go into great detail because a lot of it's pretty much the same as what we would see with an adult, but we do see a growing population that are high-tech kids. Kids are going home with G-tubes, J-tubes, they're going home with ventilators depending on different situations, shunts in place, urinary catheters, colostomy bags, and for us to know what to deal with them, it's really not feasible to do so. The biggest thing to remember is that the parents or the caregivers are trained on how to handle these situations. Now, there's always going to be times where they don't know, they get too excited, they call you guys. You always have medical control, but anytime we're dealing with any of these other types of devices, a lot of them you can just go ahead and clamp them or do whatever you need to do and then transport the patient. So again, with kids with central lines, a lot of them have so many different types that are out there. It's no different than the adults, just making sure that there is no infection coming from them, that they haven't become dislodged. A lot of these kids will have some type of occlusive dressing over the top of it so they necessarily cannot pull it out and dislodge it. But we want to make sure that there is no infection going to them, no phlebitis of any type. We see the IV catheters for kids being used to administer medications, chemotherapy, to give them fluids if necessary, go ahead and give them medication if they need it, or any other nutrition. A couple different types, the totally implanted, the multi-lumen, and then the PICC catheters. Cerebral spinal fluid shunts are something else you might actually see out there. This a lot of times can scare a lot of the paramedics because what kind of complications? We might see, well, who has it? Those that have had meningitis, those that had hydrocephalus, brain injuries, brain tumors. But in the ventricles, they've got too much cerebral spinal fluid building up. So they have a shunt that kind of goes, as you can see, up through the ventricles of the brain, and then the catheters end up going down into the abdominal where it's basically reabsorbed back into the body. But these shunts a lot of times can get clogged up, which is going to cause the patient to have headaches, double vision, blurry vision, nausea, projectile vomiting, kind of the same signs and symptoms you might see with anybody else with increased intracranial pressure. So we kind of watch for Cushing's triad with these kids. You know, the elevated blood pressure, the slow heart rate, the erratic breathing. Some of them too with this will go ahead and they can kind of push along right behind there, you'll actually feel alongside the head, it'll be kind of almost like a catheter that you can push against that sometimes will go ahead and kind of help free any occlusion that might be there. What are we going to do for these patients? Well, administer oxygen if they need it, and watch for signs of neurological deficits. Now, anytime we look at our stroke protocol says that if the patient has neurological deficits, we're going to ventilate a little bit faster to go ahead and help decrease some of the intracranial pressure. Doesn't always work. Use your end tidal with these patients. Keep it at 35. Remember, oxygen vasoconstricts, CO2 vasodilates, so you want to find a happy medium. For adults, we ventilate once, about 20 times a minute is what we're looking at, once every 3 seconds. G-tubes with kids, no different than adults. Again, most of these kids, you have to be very cautious that they don't aspirate because parents lie them straight on the floor. They don't elevate their head all the time when they're feeding them. Again, it can go ahead and cause them to aspirate. It goes up the esophagus when they're laying flat and the child will aspirate. They will go ahead and use it for giving medications. Anybody that has abdominal or gastric problems, they'll put this in. Same as the adult, brain damage or muscular dystrophy. Button catheters, that button catheter type G-tubes, or the ones, the stomach, they're just a little port outside the body. You can see how it's put right into the stomach there. And then it kind of, the G-tube ends, you can see even two G-tube, J-tube ends right down there, right at the top of the small intestines. Here we go with our pneumatic dope again. Dope will help with a lot of things, you know, that displace the obstructed. Here you can have peritonitis or perforation of the bowels. Anytime you might have some kid complaining of severe abdominal pain. And then take a look at the equipment. Is it kinked inside? Did it have a crack in it? Take a look to make sure that there is no pump failure if they have a feeding tube. If you notice a patient with this and there is some type of bleeding, again, direct pressure at the site. If the area becomes dislodged, go ahead and take a dry sterile dressing over the area. If the tube is blocked and you see the abdominal distension or the child is vomiting, stop any feeding. Anytime there's any problems with that, I usually tell parents to go ahead and stop the feeding until we can figure out what's going on. If the kid looks to be dehydrated or have hypervolemia, has been doing a lot of vomiting, go ahead and start an IV on them, give them fluids, and make sure you're protecting that airway. Keeping their head elevated so that they can go ahead and not aspirate any of the nutrition. Different colostomy again, this is what I was telling you before, they'll have some type of area that's right on there that's got that wax ring and it'll stick right to the skin. Again, you're looking for any redness around the outside. Is the gastric contents actually starting to erode the skin, causing any problems? Got something like that, there's no point in touching it, okay? If the tube or if the bag is off and you can't get a new bag on it, just go ahead and put a moist dressing over the top of it and transport it, okay? Cover it up, then you'll never know about it, right? So when is one in? They've got some type of malfunction with their intestines or urinary system. You'll have the open stoma drainage, which will drain right into a plastic type pouch. Some of the signs and symptoms that you might see are problems, peritonitis, some type of infection, redness, again, some type of infection around the opening, breakdown of the skin from any gastric contents or the fecal material. These patients, if they're septic enough, they can go ahead and end up becoming, or if they have an infection, look for those SIRS, the increased heart rate, increased respiratory rate, increased temperature, and look for any signs and symptoms of sepsis. Direct pressure at the site, moistened saline, sterile dressing covered by the dry dressing if your stoma in that area is exposed. Give them fluids if you suspect any type of hypovolemia. Here is a type of nephrostomy tube. Actually goes ahead and goes into the kidneys to help drain off any waste or urine that may, for whatever reason, can't be draining on its own. Others will go ahead and have urinary tubes. It could be the fact that there is some type of an obstruction in the urethra, and so they'll have to put one of these in place. So they're looking to drain the urine into a plastic pouch, mainly through the catheter in the urethra. Some of the big signs and symptoms that we see is UTIs, altered mental status, very common for adults, could also be the same for pediatrics. So look for signs of infection. Watch for signs of sepsis. You know, are they, do they have that SIRS, the increased respiratory, heart rate? Do they have peritonitis, extreme abdominal pain? Is there blockage that they actually can't see the draining into the pouch? And if that's the case, you know, maybe they have a distended abdomen. If you see bleeding, again, direct pressure. If the stoma is exposed, moisten sterile dressing over a drive, and then administer fluids if you suspect this patient is shocky. Okay. Anybody? God, I am just. Am I going too fast?
No.
Okay.
Slow down.
Slow down.
Are you kidding me, Alfredo? You go to Fort Rennes?
All right, patients that need dialysis. Now, there's basically two types of dialysis. Well, dialysis is a way for an external way to basically clean the blood that the kidneys are not doing. Kidneys are namely responsible for filtering any waste from the blood, and it helps get rid of excess fluid overload in a patient. Also helps balance electrolytes and keep us at that homeostasis levels within our blood, keeping the pH levels at their norm. So with someone who is set up for dialysis, they're going to have some type of vascular access in order to connect the dialyzer. And those that are needing to be dialyzed a couple times a week will usually have a fistula or graft put into place so they don't have to constantly be poking the patient. Now, hemodialysis will move blood through at a high rate, a speed, through a dialyzer, and then it returns blood, almost a pint of blood to the body every minute. And access is needed to allow blood flow to and from the body at a high rate. So, there's your AV fistulas. This is the most common type that's used in dialysis. This is mainly gone ahead and by taking the vein and the artery, connecting the two, and then having a small hole in between where blood can come down and it can go back in and be put in. Now, you're going to go ahead and see that on the arm. I mean, you can actually, it's like a little bulge with the vessels. Almost looks like a varicose vein for that matter. Vein is expanded mainly to increase blood pressure. And right at this level, you'll have a mixed AV blood. So yeah, you'll see kind of somebody's arm and you'll see these like snake-like type things underneath their arms. We want to make sure that we are not doing a blood pressure on them and we are not accessing them. The other one is the AV graft. They'll put a little graft here and it'll hook up to the artery and the vein, and then they'll have other catheters that'll come out. One will go to the machine and one will come from the machine. So you'll see that kind of occur for these patients. So we don't ever want to start an IV on the same arm where we see a fistula or a graft present. We don't want to take a blood pressure on those arms. Now, in the event of a cardiac arrest, we can contact medical control and ask to get access to be able to the AV grafts, but you guys have the ability to go ahead and use the EZ-IO. It's probably going to be a lot faster and a lot easier for you guys to do so. So again, don't take a blood pressure on the arm where there's an active graft or fistula actually present. So there's two types of dialysis. You have your hemodialysis and your peritoneal dialysis. People that are hemodialysis patients will usually go out 3 times a week, 2 to 3 times a week. They'll go to a dialysis center, and each one of these events can take anywhere from 3 to 4 hours for them to do. Blood is going to go out in through the filter here, and then it is going to return to the body after it's gone ahead and filtered out those excess fluids and toxins and tries to restore the electrolytes. In the filtered blood is forced into very hollow little fibers where the dialysis actually takes place. So you can kind of see, kind of goes out, pressure monitor, pump goes ahead, it gets an anticoagulant so it doesn't go ahead and clot, goes into the dialysizer, comes back out, air trap and detector to make sure that we're not sending anything back into the body, and goes back in at that point. So some of the problems that we see with patients who go through hemodialysis, hypotension, or it can be hypertension, fluid overload. Someone might become anemic. They might have muscle cramps due to lack of sodium within their system. They can also have problems with their calcium. If we have a patient who's doing their own peritoneal dialysis, this is mainly, they hook up large bags of dialysate or something like that it's called. It goes into a catheter there into the peritoneal area, kind of flushes around and absorbs all the toxins at that point. And then there's another catheter that will drain it out that's usually lower. It still takes about 4 to 6 hours to complete, so some people will do this at night when they sleep or when they take a nap. It's going to put about 2 to 3 liters into the peritoneum, and then the dialysate absorbs all the toxins through the capillaries. And you can see here is the big bag of dialysate that's in there. It goes into the peritoneal area, and then there's a catheter that comes out, and it will be the waste fluid that drains out of that area. If you come upon a patient that is in the middle of a dialysis treatment with peritoneal dialysis, do not clamp anything off. Just make sure that you're hanging the bags above and below the patient's abdominal area, and you can continue on with it. Look for any type of infection around the level of the entry of the catheter points, any redness, anything that's warm to the touch. Patient can have peritonitis. Look for hernias, and some things that the other patient may complain of is some type of weight gain. Now, if we have a patient that ends up with hyperkalemia, best seen in V3 and V4, you're going to see those tall peak T waves. We currently have sodium bicarb that will administer at 1 amp, and 1 amp is 50 milliequivalents per milliliter, or 1 milliequivalent per milliliter. It's 50 milliequivalents for the whole amp. In our protocol, it only states to use it in the event of cardiac arrest in someone that might have had, a dialysis treatment or some type of renal problem. Other medications that can be used for hyperkalemia is that is albuterol. Albuterol causes a shift in potassium ions at the serum level, and it has been known to reduce potassium a little bit. Normal potassium is 3.5 to 5. When you get up above that 3.5 and you start to get to the 7, your P waves are going to disappear, and you're going to start to see more on the lines of a sine wave. It's a pretty wide QRS complex, and you really don't see, it's pretty slow at that rate too. And your patient's coming close to going into VTAC or VFib.
Thank you.
Oh, they got this. Oh. Anybody have any questions? Yeah? What is that, Gary?
I haven't said nothing, my rose. My own race.
Do you have anything you'd like to add?